community conversation about important health issues. This is one in a series about key health concerns. I'm Donna Jacobs, Senior Vice President at the University of Maryland Medical System, and I will be your moderator today. Our Let's Talk About Health series is designed to do three things: increase awareness about important health issues, provide people with the tools they need to help them maintain or improve their health, and three, improve patient and provider communication. To that end, parts of this conversation are framed in ways that we recommend patients engage with their providers. We'll suggest specific questions that you might want to ask when talking with your provider. UMS conducts a community health conversation in this virtual webinar format every month at noon so people can join during their lunch hour. Our topic today is women's health, and this will include a vast array of subjects from chronic disease to reproductive health and more. Leading our conversation today is Nakia Ware. Ms. Ware is a board-certified women's health nurse practitioner at the University of Maryland Charles Regional Medical Group in Waldorf, Maryland. She's a graduate of Delaware State University, where she obtained a Bachelor's of Science in Nursing with a minor in nutrition. She received her Master's of Science in Nursing, Women's Health Nurse Practitioner degree, it's a mouthful, from the University of Cincinnati. She has several years bedside nursing experience in high-risk labor and delivery, and she is passionate about delivering total and complete health care with an emphasis on educating women and adolescents in their reproductive health. Before we get started, just a couple of very quick logistic issues. Please feel free to use the Q&A box on your screen to type in any questions that you might have as Ms. Ware is speaking. And we'll be happy to turn to those questions at the end of her discussion and address as many of those as time will allow. If we don't get to them all today, we'll certainly post them up later. Many people ask as we do these webinars whether the slides are available or whether you should take notes seriously. The slides will be available to you in a couple of days, and more on that later. And with that, Ms. Ware, would you get us started, please? Welcome.
Well, first, I just want to thank everyone for joining us today. Like Ms. Donna said, that this topic is going to be on women's health and different things with women's health. So we will start, and we will have a couple of segments where we use the Ask Me 3, where I will have a question stating the main problem, what needs to be done, and why it's important to be doing this. So first, women's health, we're going to discuss what you already know, what you should know, and what you need to know. So on average, as most women already are probably aware, women are more likely to visit their healthcare providers for annual evaluations than men. Women tend to be more in tune with their bodies and have no issues or concerns, especially if they have an established provider going to seek care, versus where men are more likely to show up to the emergency room or an urgent care for problems than to go to a primary care or a specialist doctor. It is very important for women to have both a primary care provider as well as an OBGYN. Primary care deals with of course, primary issues. You know, if you have heart disease, heart issues, high blood pressure, normal common cold symptoms. Of course, you know, a lot of women tend to just go to their OBGYN for everything, but it's very important to still see both, because the primary care can also help manage chronic conditions, whereas the OBGYN is more focused on your reproductive health. Primary care you should establish a primary care provider between the ages of 18 and 21. Most women see their pediatricians up until that age. Depending on your pediatrician, they may see you longer. Most of them try to scoot you out once you get towards 18, 19. Some will allow you to stay until 21, but it's very important to kind of break that leash and go ahead and get a primary care provider. Now, as far as care with an OBGYN, you do not have to come here just when you're pregnant or when you're trying to get pregnant. And years ago, most women started to go to their OBGYNs when they began to have sexual intercourse or if, of course, they were pregnant. However, I have seen patients as young as 12 and 13, and you can establish that as soon as you, especially if you're having issues with your menstrual cycle, so you can establish care with the OBGYN as early as 13 or whenever your period starts, and of course, once you begin to engage in sexual intercourse. So we're going to talk about a couple of age-appropriate recommendations. All women should have a regular well-woman exam once a year, regardless of your age. So that is one visit with your primary care provider for a full physical. They'll check your heart, your lungs, make sure your urinary system is okay. And you should also have a visit with your OBGYN once a year. A pap smear, which is a cervical cancer screening. We'll talk about this a little bit further in depth because some women are confused about a pap smear versus a well-woman exam. Should begin at the age of 21, regardless of sexual activity. So years ago, guidelines used to say for as soon as you began to have intercourse, you needed to come in to get a pap smear. Guidelines, as more research has been done, things have changed, and you should now begin to get that at the age of 21. There are also some changes as far as the guidelines with that. Years ago, it was every year. Now there's been some changes to that as well. We'll talk about that a little bit later and probably the next slide. The next is annual mammograms. Annual mammograms should begin at the age of 40 unless a medical history indicates sooner. So if your grandmother, your mother, someone had breast cancer, or if you've had a history of some abnormal masses or lumps or things like that before the age of 40, it may indicate you start to begin having mammograms a little sooner. As far as a colonoscopy or your colorectal screening, that should also be done beginning at the age of 50 unless history indicates sooner. There are some things that will have you come get it sooner. Of course, family medical history. Sometimes as far as women and your race, African Americans should start being screened a little sooner than age 50 for colorectal cancer. And then, of course, your bone density, your DEXA scan should begin at age 65. Of course, there are some recommendations if you've had a history of bone loss, breaking your bones, hip replacement, and things of that nature may require you to get it a little sooner. And something that I don't have on this slide that's also very important is your annual or your immunizations. Annual flu shots are very important to get, especially now with the COVID-19 pandemic. It's very important that we try to stay as healthy as possible and, protect ourselves as much as we can. So flu shots, of course, those over the age of 65, your pneumonia shots, and annual screening. So here I have a chart with some of the leading causes of death in women. This blue area here where it kind of makes up majority is heart disease. Heart disease is the #1 cause of death in women in the United States. A lot of women have cardiovascular issues, whether it's high blood pressure, they have a family history of it. Very important to maintain a healthy diet, making sure that you follow up with your primary care. That's one of the main reasons you should go because we want to make sure all of your levels are appropriate. Lab work, things of that can help get you. We want to do preventative care. We want to try to get you before you have an issue. Followed by cancer, which is about 20%, 20.7%. The rates start to decrease significantly with chronic lower respiratory disease being 6.2%. Those include COPD, emphysema, and cystic fibrosis, which we know is genetic. It's inherited. We have strokes at 6.2%, Alzheimer's disease at 6.1%, unintentional injuries, car accidents, things of that nature at 4.4%, diabetes at 2.7%, influenza and pneumonia at 2.1%, kidney disease at 1.8%, and septicemia at 1.6%. Now, these are all percentages based on no specific race, no specific age, no specific state. This is just women in the United States. Now, of course, these kind of change depending on race, age. Of course, when you're a teenager, it's more likely that your cause of death will be something like a unintentional injury, like a car accident or something, or maybe even like a suicide increases when you are younger as well as when you're older. But this is just overall in the United States, these leading causes of death. Now, when we talk about your reproductive health, the main goal of managing your reproductive health is to guide you from the start of your menstrual cycle until menopause and beyond. A lot of women decide, like, once they go through menopause, there's no need for me to go to the doctors anymore. There's no need for me to go to my OBGYN. I'm not having a cycle. I don't plan on having any kids. There's no real reason for me to go. I can go to my primary care provider. And that's not the case. You should still continue to see your OBGYN annually. Things that are discussed at your reproductive health visit, we can talk about your menstrual cycles. You know, a lot of women battle irregular cycles, whether it's being caused by some hormone imbalance, whether there's some structural things going on, fibroids, ovarian cysts. You can talk about your fertility. A lot of women, which is something that's not talked about a lot, have issues with infertility. It's not just an older woman thing. I've had patients come in the office at 26 and 27. They're married. They're trying to conceive. Those are things that you want to discuss and you want to get a hold on earlier, okay? Birth control management, there's different things that we can do. Most people decide that they only need to come to their OBGYN if they're not trying to get pregnant or if they're trying to get pregnant or if they are pregnant. We also do screenings for your sexually transmitted diseases. That should always be done annually. And, of course, that should increase depending on your lifestyle. Obstetrical care, of course, you come to see us when you are pregnant. We talk about menopause here, and we also go over things like depression, including postpartum depression, and that's something that I'll touch on a little bit later as well. So our first Ask Me 3 is here. So the problem states, I am 26 years old with a history of irregular cycles. I have not had a period in 3 months, and I am actively trying to conceive. Every pregnancy test I have taken has been negative. So to start with that problem, there are several possible causes for irregular cycles, no matter what your age is. Of course, the first thing that you should do is come in to be evaluated so that we can discuss in further detail. You should schedule an appointment. We'll do an assessment. That's what you need to do. We'll do an assessment. It'll include a physical. We'll do lab work if necessary and possible imaging. Why is it important for me to do this? Anytime you have any issues, especially in reproductive health, it's very important to know the cause. The way that I practice, I'm always a cause person versus, throwing medications. We always have to get to the root of the cause because sometimes, yes, medications and different treatments can help you to manage it, but you always want to know the underlying cause. And having a normal cycle is very important in knowing when and how to conceive because if you don't have a normal cycle, it'll definitely make it a lot more difficult to conceive. So we'll talk about your routine well woman exam. So during your routine well woman exam, it is important to give the most accurate information about your history. So family medical history is very important. We ask a lot of questions about cancers, breast cancers, ovarian cancer, uterine cancer. There's a genetic link to all of these things, and it's very important that we know those things because later down the line, you may realize that something in your family history has made you a higher risk for certain things. It's very important to come for your well woman exam so that you can ask questions. There's no stupid question. There's nothing that we can't, some things, of course, are not in our scope, and we may refer you to that appropriate specialist. But it's definitely your time to ask questions when you come to your provider. Our job is to make you comfortable enough to where you feel comfortable in asking us the appropriate questions. Now, when we talk about the pap smear versus the well woman annual exam, a lot of women come in or they schedule an appointment and say, I'm due for my pap smear. Now, a pap smear is a test, okay? The pap smear is a test that you get done to screen for cervical cancer. That is not something that recommendations state that you get every year. Now, there are some specific cases where you will get a pap smear every year if you've had a history of abnormal pap smears, if you have a history of HIV or AIDS. Those are reasons why you would get a pap smear every year. Other than that, there are age-appropriate recommendations as far, and they usually range between 3 to 5 years, depending on your age category. The well woman exam in itself is the same exact exam. You come in, we do your breast exam, we make sure your stomach is okay, make sure you don't have any issues with your urinary system, your cycles are normal. We still do a pelvic exam. However, we do not do the pap smear, which is the test. So every year you still get a pelvic exam, but you do not get a pap smear, which is the test every year. Of course, during your well woman exam, you'll also discuss birth control management. If you're already on birth control, if you want to get on some kind of birth control, same thing that I was saying before as far as fertility. This is your time to start to discuss some changes. If you and your partner have been trying, we can go over some things that you can do prior to referring you to a fertility specialist. There's sometimes things that we can do. Maybe you're not tracking your fertility appropriately and you're trying at the wrong time. You don't know when you're ovulating. So there's some things that we can do before referring you out. We'll also talk about your menstrual cycles and menopause. Menopause is a big menstrual cycle. Menopause are the two biggest issues, of course, that come in through here. Women are having hot flashes, night sweats, insomnia. They're not able to sleep. They want to know what they can do for those things. And, of course, during your well woman exam, we'll also do a breast exam. And we can, I like to go over with my patients how to appropriately check your breasts because it's more about knowing what your breasts feel like. So here we have the most common cancers in women, and this is more so your more reproductive cancers. The number, I have them listed in order from the most common to the least common. Breast cancer is the most common cancer in women, reproductive cancer, followed by cervical cancer, ovarian cancer, uterine cancer, and vaginal cancer. A lot of these cancers you may not pick up on initially. You as the patient may not know that something is wrong. A lot of times these are picked up during your annual exam. Your cervix looks a little distorted. When I'm doing your bimanual exam and pressing on your ovaries, you have a lot of pain or you have bleeding when you shouldn't. Your uterine line, your uterus feels heavy. You're having abdominal pain. And for vaginal cancers, a lot of times the number one thing that people complain about is itching. They'll itch and they think it's a yeast infection, and it's not a very common cancer. So I don't want you to think, oh no, I'm itching, I have a vaginal itch, I have vaginal cancer, because it may as well be some kind of irritation. But that is something that is linked to vaginal cancer, but it's very rare to have vaginal cancer. The number one is breast cancer. Here we are with our next Ask Me 3. I am 30 years old. My mother and maternal grandmother had breast cancer and were diagnosed before the age of 40. When should I start getting mammograms? So remember I said that annual mammograms would start at age 40. This is one of the times where that recommendation has a loophole. So if you have a first-degree relative, more than one, that's mother, sister, grandmother, who has been diagnosed with breast cancer prior to the age of 40, the recommendation is for you to begin your mammograms 10 years prior to the earliest age of diagnosis. So if your grandmother had it at 40, but your mom had it at 37, 27, we'll start looking at doing some kind of mammogram or some breast imaging. What do I need to do? So begin, if you have not already done so in this patient, they should start performing self-breast exams. Like I said before, the most important thing, and I can't stress this enough, is to know what your breasts feel like. Everyone's breast feels different. And as your provider, I see you once a year, so I can't remember everybody's breast. So there's a chance that you may pick up on something sooner than I will. Once you talk to your provider, a referral will be given for a mammogram test. And you can also request for genetic testing. There is a genetic link to breast cancer, and I'll talk about that in a second. And why is this important? It's very important to do this because early detection is key. Studies show that those with with a strong family history of breast cancer are at a higher risk, and it shows that the prognosis for breast cancer is much greater in women who discover it very early. Now, when we talk about your breasts, again, I can't drill it in. Know your breasts. Some women's breasts are very dense. They have dense, what we call dense breast tissue in the medical field, meaning that it's just hard to push through. So occasionally you may be feeling on your breast, and it's not really soft. It's not like soft like a pillow where you can go straight through it. Some women might have a little lump or a little bump in your breast, and it's kind of sometimes we have fibrocystic breast tissue, which causes your breast to be a little denser. Screening tools will be, of course, a mammogram, an MRI, an ultrasound. Some women do have to get ultrasounds after a mammogram because they can't really see through all of that tissue. And then, of course, the clinical breast exams. I have here on this slide different ways to check your breast and as well as things to look for. Rashes, redness, if you have discharge sometimes from your nipples, if you have skin changes or dimpling, sometimes it can look like an orange peel, and that is also a sign that we may need to do some kind of intervention sooner. So we have here some risks for breast cancer. There are several risks that you can change, and there are several risks that you absolutely have no control over. As we get older, that's something that we can't change. Of course, the older you get, the more at risk you are for breast cancer. Most breast cancers are diagnosed after the age of 50. There is a genetic mutation, which I was saying earlier. So inherited genes such as the BRCA1 and BRCA2 genes show a link to breast cancer, and if you are positive for those genes, you're at a higher risk for both breast and ovarian cancer. So sometimes, like I said before, if your mom, your grandmother, somebody has it, you can talk to your provider and see about getting that genetic testing done just to see if there is a link. Reproductive history. So women who start their menstrual cycle before the age of 12 and women who go through menopause after the age of 55 have an increased risk of breast cancer. And the main reason why that is because you're exposed to hormones a little bit longer. So you've been having a cycle, your estrogen, progesterone levels have been managing themselves for a long period of time, so it increases your risk of breast cancer. As before, like I was saying, the dense breast tissue, so having the connective tissue, it makes it hard. It's more so it makes it hard to detect breast cancer than increasing your risk for it. And a lot of times it can be missed if you don't do those annual mammograms, ultrasounds, and that self-breast exam. That's why it's very important to know, because you may notice that I know that my breasts are dense, or it's a little bit harder for me to feel through them, but this time I noticed that there's some kind of nodule or a little bit more, something protruding a little bit more. Personal history of breast cancer or certain non-cancerous breast disease. So if you've had breast cancer, of course, you're at a higher risk for getting breast cancer again. And if you've had other lobular carcinomas or atypical hyperplasia, these are things that your doctor will probably tell you because you wouldn't know otherwise. Those will also increase your risk of breast cancer. Same thing again with the family history of breast and ovarian cancer. Not being physical activity. If you are obese and overweight after menopause, those are also things that can cause you to have an increased risk for breast cancer. Now we're going to move on to talk about mental health. I feel like this is very fitting, especially during the time that we're in right now with the COVID-19 pandemic that we are going through. I have seen a lot of women coming in with anxiety, depression that either had it before or not, and it's worse now than ever, and as well as new onset. It's just a lot going on. The definition of anxiety is the anticipation of a future threat, and is often associated with preparation for potential danger or evident behaviors. And they can be broken down into several categories. You have general anxiety, where you're just excessive worrying about everything. There's no specific link to anything, everything you're just anxious about. And then you have the social anxieties where, sometimes you're just more you're worried about when you have to get put on a spot, or you're worried about when someone might judge you. Some people have social anxiety when they get in large crowds, or when they have to present a project, or um, when they have to do something, like I said, that possibly potentially exposes you to someone judging or placing scrutiny on you. The other the other form of mental health that we usually talk about here is depression. So, depression is persistent feeling of sadness, hopelessness, empty, or lack of interest that can interfere with your daily function. Now, some days we all have our days where we just don't feel like doing anything, and it doesn't always have to give you the diagnosis of depression. You can just have a day. But if you start to feel like it's interrupting your daily life functions, you're not able to function at work, you're not able to take care of yourself mainly, or others, then it's something that we might need to discuss in further detail. We have postpartum depression, which is very, very, very frequent. A lot of women who have kids, regardless, you can have 5 kids, it can be your first child. Postpartum depression is just an intense feeling of sadness, anxiety, or despair that lasts for 2 weeks after delivery, and it can prevent you from doing your daily tasks. It usually starts between week 1 and week 3. So once you get home, you get settled, and of course, once you get home, you try to give yourself some time. But after a week or so, if you're still feeling overwhelmed and you feel like you can't really do anything, it might start to set in. Some women are fine and they kind of, just get through it with support and help. Others sometimes need some kind of medication or therapy to help. There is a condition called the baby blues. It's oftentimes confused with postpartum depression. Some women like to say they don't want to identify with having postpartum depression. So the baby blues is something that only lasts a few days, and sometimes it gets better within a week. Most of the time, it gets better within a week or two without depression. If it does not get better and it lasts longer, that's when we start to fall in that postpartum depression phase. Um, Intimate partner violence. During this pandemic as well, there has been an increase in intimate partner violence. Intimate partner violence is defined as sexual violence, physical violence, stalking, or psychological harm by your current or former partner or spouse. This can occur in both heterosexual and same sex couples and does not require sexual intimacy. You do not have to be intimate with a person for them to inflict intimate partner violence on you. Most victims of younger than age 25, and in 2007, intimate partner violence committed 14% of all homicides in the U.S. Doesn't seem like a big number, but that's a lot when you base it on the population of the United States. And astonishing fact, 1 in 4 women have experienced contact sexual violence, physical violence, and or stalking by intimate partner violence during their lifetime. One of the things that I do want to mention is that emotional violence, intimate partner violence, is something that is very real. A lot of people confuse, they think if I'm not being, or domestic violence, if I'm not being hit or, physically harmed, I'm not in an abuse. And emotional abuse is also usually the first types of abuse that start. It starts with, name calling, um, isolation, making you feel down, making you feel like you're dependent on them, and then it typically advances. So we have a little interactive part here on intimate partner violence or domestic violence. These are some true or false questions. If you could, in the Q&A box, as I read the question, just type if you believe that this is true or if it's false, and we'll go from there. So the first statement states that victims provoke their partner. Do you guys believe that is true or false? Okay, so I'm just going to let you know that that is false. There is no excuse for domestic violence. No one inflicts any harm on themselves. Of course, you see where, sometimes when you hear about domestic violence, the first thing someone might say, well, what did you do to make them do that? And nobody can make you do anything, okay? The next statement is domestic violence is an impulse control or anger management issue. Right? So I'm going to say that this one is also false. This is a very, very, very common misconception. People think that when someone up and just starts to become angry or hit you, they have a problem. They just have an anger management issue. They need counseling, or they just did it. They didn't mean to do it. They just did it. And most of the time, abusers are deliberate. Okay. Sometimes their reaction is quick and they don't necessarily think. However, domestic violence is a constant and repeated behavior. So there's an abuser would not hit their boss. That is something where they have an anger management issue. If you would just hit anybody, then there may be an issue. But if it's just with you, then or just with your kids, then it may be just that and a deliberate act. The next one is domestic violence will get better after I have a child or I'm pregnant. That is also false. Unfortunately, domestic violence actually increases as women have children, and it's amazing how and unfortunate how many pregnant women battle with domestic violence. It's more so as the abuser has more control. You care about something more, or they in their mind they may think that you care about something more than them. So the abuse usually gets worse. And lastly, it is easy for a victim to leave their abuser. So if he or she doesn't leave, it means that he or she likes the abuse or is exaggerating how bad it is. And of course, that is also false. You never, never, never try to make it seem like it can't be that bad if you're still staying. A lot of the time, the victims do not leave because they are scared. They lack somewhere safe to go. They don't want to put anybody else in harm's way. They don't want to go to their parents or their friends because that may cause the abuser to harm someone else. And sometimes it's, they don't feel like they can survive without them. Like they may need them. You may be home and this person works and they provide everything that you need. So if you were to leave, you wouldn't have anywhere to go. So they fear that they don't have any safe options. And then here I just have provided some intimate partner or domestic violence resources. There's a Maryland Network Against Domestic Violence. There is the 211 Maryland. You can call or text it. There's the Ruth House, and there's the National Domestic Violence Hotline. There's there's websites for all of these as well as phone numbers. And lastly, communities and countries and ultimately the world are only as strong as the health of their women. And that is a quote from Michelle Obama, and I truly believe it. We are the forefront of everything, and it all starts with our health. And these are just some resources from if you need more information about cancer, heart disease. The CDC has lots and lots of information on there. And you can also go to our website to find some information. That's the first one up there.
Nakia, thank you. That was tremendous. I really enjoyed your presentation, and we still have the same number of people on the line that we had when we started, so it's very clear that folks are getting a lot of information out of your presentation and enjoying it very much. So let's turn to some Q&A, if you will. There are three questions, two that are almost identical and one very related, and they have to do with pap smears, hysterectomy. So I'll read the first question, and the second one goes along with it. I had a hysterectomy many years ago. Do I still need a pap test, and if so, how often? The related question is specifically, after the age of 60, how often should you get a pap test?
Okay. So with the first question, these are both really good questions. With the first question, after you've had a hysterectomy, usually, and it depends on what kind of hysterectomy you had, there's different types. Most providers, when they have a hysterectomy, they'll leave your ovaries. If you've had it before, you go through menopause so that you will not go through menopause. And then some providers, depending on why you're getting it out, if there is some malignancy or something like that, you may have everything taken out. Now, once you do your hysterectomy, the provider usually does a pathology report to make sure that there are no cancer cells or anything. And as long as you have a pathology report that says everything was fine, there's no need to do a pap smear. A pap smear is literally for us to test your cervical cancer cells. Now, occasionally I do have patients who I've never seen before who've had a hysterectomy. I have none of their records, and I do what's called a vaginal pap. So I pretty much take cells from the vaginal cuff, which is what's left after they remove your cervix and your uterus, and send that off to make sure that everything is fine. As long as that is okay, there's no need to do a pap smear. You still need to do your well woman exam, but pap smear is not required. And the second question, after the age of 60, how often do you need to get a pap smear? The recommendation is after the age of 65 that paps are no longer needed unless you've had a history of abnormal paps within the last 10 years. So if you're getting your pap smears done every 3 to 5 years, that means within the last 2 to 3 paps that you've had, as long as those have been normal negative, there's no reason to do a pap. Now, if for whatever reason we do a cervical exam and we see something looks a little suspicious on your cervix when we're doing your well woman, we may go ahead and do a pap smear, but recommendations, you don't have to get one after the age of 65 as long as the ones prior have been normal.
Great, thank you. Turning to the issue of mental health, here's a question. How is anxiety different from panic attacks, or are panic attacks a symptom of anxiety?
So a panic attack is a symptom of anxiety. Oftentimes, in order to have a panic attack, something has worked you up to where you are very anxious about something. A panic attack is very specific. Sometimes it's random, and it's usually just a buildup of emotions that you may or may not know that you have. And other times it's brought on. You sense that you're about to start losing it and you can't really control it. So it's a form of anxiety.
There's a question here about intimate partner violence, and it asks about the abusers. The question is it common that the abuser may have been exposed to or experienced abuse themselves in childhood?
I do see a lot of the times, especially once the abuser seeks help, a lot of the times, and it's the same thing with sexual assault, a lot of the times they have been exposed to it, or they've seen it, or it's happened to them. It happened in their household. Maybe they witnessed their mom or their dad getting abused, or a close relative, and it's something that is it's not an excuse for it, but it's oftentimes very common to see that there is some kind of link.
And a couple of questions, this might be the end, a couple of questions related to menopause. Are there any natural therapies that are effective in helping with the side effects of menopause, like hot flashes, trouble sleeping, mood swings? And then a related question, is hormone replacement therapy safe?
Okay, so we'll start with the question on natural therapies. One of the things that I know for sure works is diet and exercise. Making sure you have a healthy diet, calcium, vitamin D, fruits, vegetables, and exercise, making sure that your body has some kind of routine. It'll help you feel better. It'll help you sleep better. As far as the hot flashes, Primrose, black cohosh is a natural supplement that I've prescribed to a lot of patients who are sensitive to hormones and or who cannot have hormone therapy. That definitely does have help with menopausal symptoms. You can buy that, Amazon, Walmart, Target. They sell them in all of the CVS, all of those stores. And of course, also making sure that you kind of avoid trigger foods. So some trigger foods include caffeine, alcohol, spicy foods, and sugary things, high saturated fats, all the bad stuff. So those things can exacerbate your symptoms, okay? And then as far as hormone replacement is very patient and person specific. Every patient cannot have hormone therapy, whether you've had a history of cancer of some sort, your body is sensitive to it, you're on certain medications, you've had a history of certain things. It's safe. Of course, with any medication or with anything, there is always something that, risk factors. And in order for you to know if it's a good option for you, of course, a full history, speaking to your provider. And our goal is to put you on something that's for the shortest amount of time for the most and that has the most effect.
All right, and one final question. There are a lot about the term self-care these days. What are your best recommendations for self-care, especially in a time like this with COVID?
Personally, I talk to my patients about this often. Sometimes self-care can just be going to your car and sitting in your car and listening to a song, reading a book, talking to a friend, like just personal, any time that you can commit to yourself, personal time. It's not much that we can do as far as, going out and treating yourself to a movie and things like that. So we have to be kind of creative, but you have to value every little bit of time. So, and it's okay. And I want people to know that it's okay to need your own time.
Great. Nakia, this has been terrific. I want to remind people who may not have been on at the beginning, if you weren't on at the beginning, you didn't hear it, or a reminder, and I'll give you in just a minute. There's a website where you'll be able to see this replay, and the slides will be available to you. I did get a question about that. I think you wanted to address this slide.
Yeah, so I just wanted to let you guys know, of course, October is Awareness Month for a lot of things, domestic violence, breast cancer being one of the main things that we talk about. We are having a breast cancer awareness virtual seminar tomorrow, correct? Yes, the 22nd tomorrow. It's from 12 to 1. You can register. It's free. This is the website that you can register so that you can join tomorrow to learn a little bit more.
Great, thank you. All right, and if you'd like to see these slides again, you can go to our website. We have a dedicated site for our Let's Talk About Health series, and it's www.ums.org/letstalk. And there you can see also the previous sessions that we've done to date, technology and telehealth, Ask Me 3, which are the 3 questions that we recommend you ask that were woven into Nakia's discussion. We've also done children's health and safety and men's health. Coming up, there are additional programs. The one for November, same time, third Wednesday in the month. It will be on diabetes, and that's November 18th, again at noon. So join us next month for more information. And we want to say thank you to you, Nakia, certainly for your excellent presentation. And thank you all for joining us today. We are adjourned.
Thank you.